Welcome to 5-Minute Journal Club, TROP2-directed antibody-drug conjugates in the management of patients with non-small cell lung cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Aaron Lisberg from the University of California, Los Angeles to discuss a number of recent publications and presentations on this subject. To begin, we focus on the first TROP2-directed ADC approved in lung cancer, datopotamab deruxtecan, now approved for patients with metastatic EGFR mutant non-small cell lung cancer and prior targeted treatment and platinum-based chemotherapy. While ADCs often require less dose reduction and discontinuation than systemic chemotherapy, the toxicity profiles are often novel, and I asked Dr. Lisberg about 3 recent papers describing the prevention and management of adverse effects with Dato-DXd.
Neil, I think it's obviously critically important as we have new therapies come into the market. Certainly, the approvals are based on both a combination of efficacy and safety. And I think a lot of us who have a lot of experience are very excited to use these drugs based on those aspects. But I think for the majority of individuals that will be treating patients with these agents, they certainly likely have very little, if any, experience. With Dato-DXd, there may be some precursor experience to the experience in EGFR mutant non-small cell lung cancer, as the approval in breast cancer preceded the lung cancer approval by a couple months. But irrespective, understanding how to manage the toxicities is critical. So again, from a high level, we can emphasize the fact that Dato-DXd does not appear to have bone marrow toxicity to any significant level. I think that's an important thing for patients and providers to understand. Certainly, you always need to be getting pre-treatment labs, but as opposed to many of our other therapies that have both bone marrow toxicity and potential nephrotoxicity, we're not seeing that with Dato-DXd. So we would not anticipate that, and although important to monitor for, not a high level of concern. Again, I think that the unique toxicities for Dato-DXd are the following. So stomatitis, ILD, ocular toxicity, and potentially infusion-related reactions, although I think if providers follow the pre-medication algorithms, I think that the infusion-related reaction numbers will decrease. So going through those one by one, starting with stomatitis. And as you alluded to, Neil, there are a number of recent publications, including my own and the oncologist and supportive care cancer, that I would refer providers to. There are nice checklists, there are nice diagrams, there are nice images to help guide these things, but taking us through kind of a verbal process. When we're looking at stomatitis, as mentioned earlier in the EGFR mutant non-small cell lung cancer population, when we're talking with our patients, more than half of these patients do get stomatitis. And so I think we should prepare our patients for the possibility that it will occur. How do we prepare for that? We need to make sure that the baseline oral hygiene is good. So we need to make sure the patients are brushing and flossing on a daily basis. And we need to prepare them for the possibility that stomatitis will occur. So I think that the actions that should be taken on day one are the following. I think that there's a lot of emerging evidence that cryotherapy can be beneficial for these patients. And what do I mean by cryotherapy? It's really nothing fancy. It's just assuring that at the time of infusion and throughout the duration of infusion, that the patients have ice or, a popsicle or something cold in their mouth. There is, again, evidence to support the idea that by using cryotherapy during the time of infusion and potentially even in subsequent days for symptomatic relief, we believe that, mechanistically that can decrease the incidence and severity of stomatitis. So a very low impact intervention that can potentially yield significant dividends for our patients. So I would make sure starting on cycle 1, day 1, and throughout the duration of a patient's therapy that cryotherapy is being used. In addition, there are a number of mouthwashes, 2 specifically, that I like to use in my patients, and I like to use them prophylactically. There is data from everolimus that prophylactic use of steroid-containing mouthwashes can again decrease the incidence and severity of mucositis. Certainly, Dato-DXd is a different class of therapy, so the ability to directly say that data will apply to Dato-DXd has not been developed yet, but efforts are ongoing to potentially develop that data. But at this time, I am using prophylactic mouthwashes mouthwashes. So I'll use a steroid-containing mouthwash, preferably one that does not use alcohol, as those can cause inflammation of the oral mucosa. However, at some time points, if alcohol-containing steroid mouthwashes are the only ones that are available, I think that's fine to be using. I would have my patients start rinsing with those 3 to 4 times a day, again, from cycle 1, day 1 on throughout duration of therapy. And then I also like to provide my patients with a symptomatic mouthwash. So magic mouthwash is kind of a colloquial term for a mouthwash containing a number of symptomatic relief agents such as lidocaine and other formulations. I think you have to one of the complicating factors is not every pharmacy will have these mouthwashes, so you have to make sure you're partnering with pharmacies that do have them. But I think using these mouthwashes throughout duration of therapy is important. Now, this is where, subsequent to cycle 1, day 1, good communication is critical, of course, throughout duration of any patient's treatment course. And I think that as patients develop these mouth sores, it's important to be communicating with them, certainly if in severe cases, which are rare, but if patients are, having inability to eat or drink, that's a serious situation, one in which that needs to be very urgently evaluated. Again, this happens in the very small minority of patients, but hydration, modifications in diets potentially. And if those mouth sores are continuing to persist by the 3-week time point, i.e. when the next therapy is about to be administered, based on a lot of experience with Dato-DXd, I like to be very cautious in that setting. So, we grade our mucositis based on CTCAE. Again, if you look at these papers, you'll see specific guidelines based on those grading. But I would argue that if a patient's continuing to have symptomatic mouth sores, and that would be considered a grade 2 mucositis, at the time they are due for their next therapy, I typically would not administer that therapy. I would delay, and oftentimes that additional week of time will allow those mouth sores to resolve. And by allowing those mouth sores to resolve, you can then give the therapy at the same dose and potentially not have recurrence. If you do a delay and you give the same dose and you again have occurrence of the mouth sores potentially requiring delay, I think that's when you have to think about potential dose reduction. Also, obviously, if there's a grade 3 event where a patient's unable to eat or drink and is losing weight, you need to delay and potentially dose reduce as well. I talk about the delay and the dose reduction, and I emphasize that because it's been very effective. Again, having treated close to 100 patients with this agent over many years, I have seen some patients have significant mucositis early on in their therapy. And in those patients with the maneuvers that we've talked about, cryotherapy, the mouthwashes, delay and dose reduction, oftentimes we've been able to go from a grade 3 event in a very small subset of patients down to grade 1 or grade 0 throughout the duration of therapy. Interestingly, in those patients that had significant mucositis early on in their therapy, and we followed this approach, I've often seen deep tumor responses and durable benefit. So I think that it's just a really important messaging to get out, the idea that even in patients that may have significant mucositis early in therapy, you can stick with the therapy, you can delay, you can dose reduce, and there's no reason to believe that the toxicity will remain as significant, as profound as it was early on in therapy. And I think that, I've even had patients get kind of annoyed with me over time. They have an early grade 3 event, I delay, I dose reduce, and then they really have no recurrence of mucositis, potentially for, in some of these patients, they were on therapy for a couple years. And I continue to ask, pretty diligently, are they having mucositis, and asking all the questions you should be asking, evaluating them out. And these patients sometimes have said, doctor, there's no more mucositis, it's okay. But obviously, just being cautious based on what happened, I think that that's a critical aspect to it. In terms of the other toxicities, ILD, I think we have a good understanding for ILD based on our experience with immunotherapy. In the vast majority of cases of ILD that occur with Dato-DXd that I've seen, they've been early and oftentimes asymptomatic. It's hard to know when radiographic changes occur on a patient's CT scan. These are patients with lung cancer that already have abnormal lungs. Is that ILD? Is it not? My personal practice pattern has been to work very closely with individual pulmonologists who sees all of my cases. And get their opinion, whether they believe it's ILD or not. Even the asymptomatic case, if they do believe it's ILD, we definitely will introduce aggressive steroid treatment. We will hold the therapy until those toxicities resolve, and oftentimes re-challenge is appropriate. If the patient does have toxicity or symptoms, then we certainly need to be very careful and probably stop the drug. In terms of ocular toxicity, we talked about this earlier. using artificial tears over the counter, saline eye drops can be very helpful up to 4 times a day. When this toxicity occurs, it's usually a cumulative toxicity. It's usually characterized by dry eyes or increased hearing, not overly concerning or problematic for patients. But if the symptoms are getting worse, I think an ophthalmology referral is important. That's happened in a minority of patients, but getting the ophthalmologist involved has been very helpful. And then I also mentioned the infusion-related reactions. I think the only point to really make there is it's very important to make sure that you're giving the pre-medications for these patients. So I think that, Ken, on, globally, especially when you compare to the standard of care docetaxel, this Dato-DXd is a better tolerated agent, does not have the bone marrow toxicity, does not have nephrotoxicity, does not have neuropathy, many of the other toxicities we see with platinum-based chemotherapy, but certainly has these unique toxicities, stomatitis, ocular toxicity, ILD, and infusion-related reactions. And it's an experience thing. Again, I would refer you back to some of the papers that have been published recently to give guidelines, checklists on how to manage these toxicities, but globally, I think that these are very manageable toxicities, and I think based on appropriate, communication between the provider and the patient, we can continue to administer these Dato-DXd and provide benefit to our patients.
The FLAURA2 randomized phase 3 trial demonstrated that the addition of platinum-based chemotherapy to osimertinib as first-line treatment of EGFR mutant metastatic non-small cell lung cancer resulted in significant improvements in progression-free and overall survival. The ongoing phase 3 TROPION-Lung14 study is evaluating whether the addition of Dato-DXd to first-line osimertinib will improve outcomes in advanced EGFR mutant non-small cell lung cancer. Another trial in progress combining Dato-DXd with osimertinib is TROPION-Lung15, which will evaluate this combination as second-line treatment of metastatic disease in patients with disease relapse on osimertinib. I asked Dr. Lisberg for his take on the fascinating concept of combining Dato-DXd and osimertinib and what we might learn from these ongoing phase 3 trials.
This is specifically looking at how Dato-DXd will perform in combination with osimertinib. So we do have some early data to support the idea that the outcomes in our EGFR mutant advanced metastatic non-small cell lung cancer patients may be improved with Dato-DXd in combination with osimertinib. That data comes from the ORCHARD trial, which was a basket trial evaluating osimertinib plus a variety of different agents in the after progression on prior osimertinib. Module 10 was an unmatched cohort, so patients did not have to have a specific biomarker to enter the cohort, but then evaluated patients who had received osimertinib, had progressed, continuation of osimertinib plus Dato-DXd. What we saw in ORCHARD Module 10 was improved outcomes for these patients, even in comparison to what we see with Dato-DXd alone. And so that really launched a lot of thought processes in terms of how we could potentially increase the benefit. Important to note that, again, as we talked about earlier in this presentation, Dato-DXd appears to certainly have a better toxicity profile than docetaxel and better efficacy outcomes than docetaxel in the EGFR mutant population. So certainly monotherapy, as we talked about after progression on an EGFR TKI and platinum-based chemotherapy at this time as a standard of care is very appropriate. But what else can we be doing for our patients? So there are 2 trials to highlight here, the TROPION-Lung14 trial and the TROPION-Lung15 trial. So the TROPION-Lung14 trial is looking at a novel frontline approach. It's randomizing patients to receive osimertinib monotherapy in the frontline setting versus osimertinib plus Dato-DXd. Again, leveraging what we saw on the ORCHARD Module 10 with the hope that the combination of osimertinib plus Dato-DXd will outperform osimertinib. Now, the question, if it does do that, is going to be how do those results compare to some of the other regimens we talked about earlier, the FLAURA2 OC plus chemo or the AMI laser combination. Certainly, we're not going to get the direct answer to that on this trial because the control arm here is osimertinib, but we will see, and it potentially could lead to another therapeutic option for our patients that would, in the intensification context would lead to a sparing of chemotherapy that patients could potentially get later on in their therapy. So we'll see how that trial plays out. The other trial to highlight is the TROPION-Lung15 study. So this is a 3-arm trial looking at osimertinib plus Dato-DXd versus Dato-DXd alone versus platinum doublet chemotherapy in patients with EGFR mutant disease. So this is ongoing. We will see how this plays out. This is, again, in the second line setting. So if this trial were positive for the Dato-DXd arm or the Dato-DXd plus osimertinib arm in comparison to platinum chemotherapy, this could potentially move Dato-DXd up a line of therapy. Again, the current approval is for patients after EGFR TKI and platinum chemotherapy. This trial is randomizing patients against platinum chemotherapy directly. And so we will see how this plays out. It'll be very interesting and potentially, either OC plus Dato in the frontline setting or potentially OC plus Dato in the second line setting could be ways for us to get the Dato-DXd TROP2 ADC to our patients earlier. As we know, these patients are sick and unfortunately they do eventually progress through standard therapies. It's important to make sure we're getting our patients the most effective therapy as early on in their treatment course as possible. And I think that both these trials are looking at different approaches to potentially do that with Dato-DXd in our EGFR mutant patients.
Prevention and management of brain metastases in patients with non-small cell lung cancer is an important focus of ongoing clinical research, and there are emerging data suggesting CNS activity with TROP2 targeted ADCs. Subgroup analyses from the EVOKE-01 study of sacituzumab govitecan suggested that patients with baseline brain metastasis did better with sacituzumab compared to docetaxel, and a subset analysis from TROPION-Lung05 and TROPION-Lung01 have demonstrated that Dato-DXd has significant CNS activity in patients with EGFR mutant disease. I asked Dr. Lisberg to comment on brain metastases and TROP2 targeted ADCs.
This is a critical discussion for us to be having for our patients with advanced metastatic non-small cell lung cancer. Unfortunately, as I'm sure the listeners are aware, advanced metastatic non-small cell lung cancer frequently goes to the brain. And, we have some agents that are really active in the brain, speaking specifically about some of our TKIs in the EGFR space and beyond. But with the exception of those really active CNS drugs, we have to be very aggressive with our CNS management, getting our colleagues, our neurosurgery colleagues and radiation oncology colleagues involved to make sure that we are adequately managing those aspects. And so the question is, do these TROP2 ADCs cross the blood-brain barrier, and what level of control do they provide? I think that on face value, the ADC is a large molecule, and it would not really be anticipated. The hypothesis probably would not be that an ADC would, easily cross the blood-brain barrier and have CNS activity. However, interestingly, there's a number of emerging data sets to support the idea that these agents do have CNS penetration and do provide a level of CNS activity, which I think is very exciting. So looking at a subset analysis from the EVOKE-01 trial, which was looking at sacituzumab govitecan versus docetaxel in patients with advanced metastatic non-small cell lung cancer, we see that patients with known baseline brain mets performed better with SG compared to docetaxel. In terms of overall survival, there was a clear benefit in the SG group. And we also know that in the patients with actionable genomic alterations, that's somewhere where we're not seeing as much difference with SG as we did with Dato-DXd, but certainly some level of control. Now, I presented at ASCO 2024 a subgroup analysis from the TL05 trial, which was the patients with actionable genomic alterations treated with Dato-DXd. And what we found there, again, was that the systemic outcomes and the overall outcomes on trial in terms of PFS were very similar, whether patients had baseline brain mets or not, which again supports the idea that patients are getting some level of CNS control. I mean, we would anticipate that patients with baseline brain mets, if there was no CNS control from the agent, would have worse longitudinal outcomes, and we did not see that. In that subset analysis from TL05, we had a limited number of patients with untreated brain metastases, and we did see some level of response there too. Again, the data from that TL05 subset analysis really didn't argue in favor of the lack of importance of definitive CNS therapy for patients receiving Dato-DXd that had brain metastases. I still think it's important to do just definitive CNS therapy for those patients, but it did argue in favor of the fact that once you start patients on Dato-DXd, they will have some level of CNS control, which I think is a very meaningful aspect to the therapy. Now, just at World Lung, there was a similar subset analysis looked on the overall population from the TL01 study. So again, these are patients both with and without actionable genomic alterations. And what we're seeing are clearly improved outcomes in patients with Dato-DXd compared to docetaxel. So the confirmed CNS objective response rate, again, in a very limited number of patients, was 16% for Dato-DXd. There were no patients in docetaxel that had a confirmed response. And then I think going back to what we saw on the TLO5 study, the overall outcomes certainly were better with patients who got Dato-DXd versus docetaxel. And when we look at the CNS PFS rates, we can see that with Dato-DXd, the CNS PFS median was 5 months compared to only 3 months with docetaxel. And again, in all patients with baseline brain mets, it was improved with Dato-DXd. We showed some cases during that analysis too, and I think that the overall take-home message here from both the TLO5 analysis presented at ASCO 2024 and this most recent update at World Lung is that Dato-DXd appears to have CNS activity. Again, not to the level that we would forego definitive therapy. I think it's, again, critical still to be intervening on our patients who have brain mets, making sure those are controlled. But I think we should have some level of confidence and reassurance that when we start our patients on Dato-DXd, their CNS will be controlled. The number of CNS progression events, which can be catastrophic for patients, is less likely to occur on Dato-DXd, certainly in comparison to our standard of care docetaxel, which I think is very meaningful for our patients and a unique quality to Dato-DXd. As we talked about at the beginning of the segment, we're seeing something similar with sacituzumab govitecan, and we see something similar with many of the other ADCs. So at this point, I think the hypothesis is that there is probably some baseline liabilities or vulnerabilities to the blood-brain barrier that allow the ADC to cross the blood-brain barrier into the CNS of these patients, that the ADC acts in the similar manner that it would in the systemic circulation to have efficacy and to kill tumors in the brain as well, which I think, is another emphasis and another important thing. Specifically, in the EGFR mutant population where we have the approval for Dato-DXd, we know brain mets are a significant problem for those patients. So giving them Dato-DXd, knowing that we will likely have CNS control while on therapy, I think is reassuring and something that I think is a real attribute and benefit to the therapy moving forward.